Hello, Andrew Kolsky with Therapy BTS, Therapy Behind the Scenes. Today we are going to be speaking with Bill Prasad, and he has a really unique background. Actually, full disclosure, Bill was my very first supervisor when I was doing an internship and learning counseling. So we go back many, many years, and I learned a lot from him. So he's an excellent resource, and I'm so glad to have you on the podcast, Bill. Can you introduce yourself to the audience for us?
Yes, hello everyone, and hello again, Andrew. From what I remember, we worked together back in about 2012. I think it was between 2012 and 2014.
Right in there, yeah.
Right, and that was in the Washington, D.C. area. So since then, I have moved to Houston, Texas, where I do three things. I work in a private practice where I specialize in leadership coaching, in addiction, and in trauma. And then I do mental health trainings for companies all over the world. Some of it is virtually, some of it is in person. And then also I do something called critical incident response, which means I am called to intervene virtually, or I intervene on site where there has been some type of traumatic event. It could be anything from the unexpected death of a colleague, or I could be called, Andrew, to a hospital where surgical team has operated on the wrong body part, or there was an unexpected death of a child. It also could be a city or a university where there's been a natural disaster or there's been a mass shooting.
Wow, wow. Well, this is certainly an interesting topic matter for us, especially since we focus on what goes on behind the scenes in therapy, what's really going on with a therapist and these issues. And to have someone like yourself who has the experience dealing with crisis response, we've never had the opportunity to explore that before. So I'm really interested in getting into that. So tell us first, how did you get into that? Why is that something that you do?
Well, you'd have to reach back to my first career. So in the mental health field, I have been in the mental health field since 2008. My first career was as a journalist. So I worked all over the country, most of it in television news, and spent the last few years between approximately 2000 and 2005 working in Washington, D.C. As I recall, my exposure to trauma revealed the biggest mistake I ever made as a journalist. And the biggest mistake was standing in front of the Murrah building after it had been blown up in Oklahoma City, reporting, and Andrew thinking this was the worst thing I was ever going to see.
Wow.
And then fast forward to 2001, I'm standing in front of the Pentagon. So innumerable exposure to trauma as a reporter, whether it was terrorist attacks, homicides, tornadoes, hurricanes. And then I segued into the mental health field. And one of the things I was interested in was trauma. How do I help people either in groups or one-on-one when it came to trauma? And that opened the door to specializing in trauma. So I'm able to serve people when it comes to one-on-one work and counseling in Virginia and Texas, since I'm licensed in both of those states, which has really opened up the population for one-on-one work. And then when we moved after the pandemic to a more virtual world, it literally opened up the world to me in reference to critical incident response.
Yeah, wow. It's I remember back to the Murrah building bombing, and literally as I'm, speaking to you right now, I could throw a stone and hit the Pentagon. And I was here when the Pentagon was hit by the airplane. My windows shook from the impact. And I think I'm, one of a few people, I mean, probably a decent number of people, but still one of a few people who actually has photos and video and all sorts of documentation, because I literally was standing here on a ridge watching the Pentagon. I didn't know what else to do. So I took video, I took photos. So it really hits home, that one in particular, because I could look right into the Pentagon and see the offices and see the desks because the walls were just sheared open.
And I'm guessing you will never forget that sound.
No, I'll never forget. I mean, there's an image in my head that is directly comes, which is the Pentagon, the walls are sheared open, the fire and the flames are on the roof. And I always remember there was this one office where the wall was sheared and there was a desk just sitting there, a desk in someone's office, and the wall was just gone. And I just remember looking into the office and seeing that desk sitting there. And that's the view that just always comes back first when I think about that.
And if you'll recall, during an approximately 10-month period, the community that we lived in, Washington and Virginia and Maryland, you could say that for a while it was the most heavily traumatized area in the world, because squeezed into that time period, we had 9/11, we had the anthrax attacks, we had the sniper shootings, and we had one of, if not the worst case of West Nile virus in the nation's history.
Wow. I forget about the others because, my main focus is the Pentagon, but you're right. The anthrax attacks, yeah, those came back. A very close friend of mine was in charge of one of the buildings where one of the anthrax attacks occurred. He had to be the one managing the cleanup or the response. So I had a very direct contact with that as well.
Right. And I'm working as a reporter, and so I was affected like everyone else. I did have to open my mail. I did have to go outside. I did have to go get gas. And as you'll recall, some people were killed in retail parking lots.
Yeah, the DC sniper.
And as like everyone else in that area, when a plane flew overhead, my immediate thought was terrorist attack when I see an airplane.
Yeah.
And then probably ingrained in me is this device right here, as in the rest of the world will see this
Wow.
as a box cutter. I don't really look at it exactly the same way.
Right. Right. Wow. Well, it's really, I mean, the fact that you're doing the work you do and the fact that you have that experience and exposure and that background, I'm sure really drives it home when you're working with current clients.
Right. It did help, and it has continued to help. And one of my first jobs, once I got my independent license, was to work for Fairfax County Fire and Rescue, which, as you know, is in Virginia. And I was in charge of their behavioral health department. And so these are men and women who face trauma weekly, at the very least. And I
Yeah.
was really drawn to that job because I wanted to give something back.
Right. I can only imagine that some of them, because of the amount of trauma they see, they must start to get numb to it. I'm imagining.
Yes, a number of things can happen. One side is that the greater the exposure, the greater the resilience, the greater of understanding of how to stay resilient. Flip side is that all of us have if this was your container for how much trauma that you can handle, well, it's not a finite container. There isn't an infinite amount of liquid you can put into that. And my experience with the fire department was that the people who I diagnosed with PTSD were generally not the firefighter or paramedic who had been in the fire service for a year. It was people who had been in the fire service for about 8, 10, 12 years because of accumulated events.
Right. Right. Wow. So with all of this background and experience, today you are doing crisis response, which is, as you were explaining to me earlier, is different from counseling. So share with the audience for us, what is crisis response? What do you do? How do you even get involved?
Well, let me plug a couple of holes in some of the misnomers about crisis response. As you said, it's not counseling. People are not ready for counseling. in the hours or days after they just stepped over the bodies of their coworkers after a mass shooting. So there's no counseling involved early. There is also no request for them to tell their story of what happened. That's another myth that really harms critical incident response work. That some people won't call us in because they think we're going to ask each person to go through the entire story.
Mhm.
So essentially, I'm called, and sometimes I get a text. So I carry my phone with me at all times. Sometimes I get a phone call either from the organization or the university or the city where the event occurred, or I get a call from an employee assistance program, and they have a client that needs critical incident response services. Sometimes I get a call or a text, and the request is, Bill, can you go to a facility here in Houston in 2 hours? Or can you do a virtual intervention in a couple of hours? In other situations, it's a couple of days. So my ability to respond immediately is very, very important.
Mhm.
And we also have to think in terms of critical incident response as, in the majority of cases, a one-off situation, meaning I go in, I do either group or I'm available for one-on-ones, and then in about 95% of the situations, I'm not called back because it's not necessary, it's not needed.
Mhm.
And the initial intervention that we do is not called the debriefing. It's called a diffusing. So when I walk in, I have three goals essentially. I want to provide some level of stabilization. I want to try to assess. In other words, it can be as simple as asking people, what do you need? Or what was your first thought when you heard or saw that this was a mass shooting? And then I provide them with education. Here are some things you might deal with over the next few days or the next couple of weeks. And then resources. What can you do? Can you talk to your employee assistance program? If you have an ongoing relationship with a therapist, this might be a good time to reconnect. Other resources could include, if you're spiritual, this is a good time maybe to read the Bible, go to church. This might be a good time to increase your exercise. Sometimes in situations where there are mental health challenges, what a person does is at times throws out exercise and eating well. And those are the two things those two along with sleep that you really have to pay extra attention to.
Mhm.
So I go into a room and those are my goals. And I have to be confident enough to own the room, but to have enough humility to send the message to these folks that you folks are actually the experts in your life. I bring in some expertise in psychology. We work together in this room. And one of the most interesting things about critical incident response is that no matter how prepared you are, at times you are really surprised by what happens. So here's an example. Andrew, think of, you're going to a company, you're going to meet with a team, and in the team, someone died over the weekend. Person had a heart attack. And
Mhm.
now it's Tuesday, they just found out about it on Monday. And you're told this person had been on with the team for a long time, and he was well respected, and people will miss him. And now you're going to be in a room. So you walk into the room, and my colleague told me this story that she started to sense that people were having reactions that were different from what management described, as in, he will be missed. He was a veteran, he was well liked. And what started to surface was that people were feeling guilty because they didn't like him. He was a bully.
Wow.
And so guilt is one of the responses that you've got to be able to handle as a critical incident responder. People may feel guilty for that reason. In many cases, in virtually every case, actually, when I'm called to a workplace and a coworker has died by suicide, there are generally a couple of people who feel guilty, who are thinking, I should have known this. I should have seen this. If I had had lunch with him, or he invited me to have coffee after work, if I had done that, I might have been able to prevent this. So there's a lot of guilt in the room at times across the board. Think of a situation where I'm called into a hospital where they've operated on the wrong body part. And you can imagine levels of guilt there. And I did work for Inova Fairfax hospitals, Inova, the Inova hospital chain, as a drug treatment counselor, both in detox and in outpatient. And as part of being hospital staff, I would go to the meetings where there were discussions about medical errors. And so I had an inside look at medical errors and then an outside look at how it affects people and their ability to function.
Wow.
During the pandemic, one of my fields of expertise is working with medical providers. So Andrew, during the pandemic, I spent many days working with hospital staff on the COVID wings. So I'm there on the wings, there are the patients, and doctors and nurses were really struggling. One of the hospital organizations that I work with that's really big here in Houston is Houston Methodist Hospital. And I'll never forget working with a medical team. And we were in the throes of one of the surges, and doctor said to the group, I am so tired of the discharge plan being death. And that just took the air right out of me.
Yeah, wow.
So I go into those situations, especially with medical providers. These are folks who want to give help. They don't want to accept help. And there can be resistance. So I have to temper my interventions and my responses based on what's the population in front of me, knowing that I could have this preconceived idea about what it's supposed to be, what the research says, and it could be something completely different.
You know, it's you really have to be ready to think on your toes, it sounds like, because you don't know what you're going to be walking into, you know. I wonder, you know, here's the thing that I'm curious about. So you come in as a crisis intervention role, and you see these people, whether it be guilt that they're dealing with, you know, there's all sorts of different things they might be dealing with. And it sure sounds like some of these people, at least, would really need some long-term counseling over some issues. How do you, in that initial meeting where you're just showing up for the crisis part, how do you work that out? Like, do you refer them to counselors or tell them that they should see? Like, what do you even do in that case?
Well, remember that throughout the diffusing, and diffusings run about 45 minutes to an hour, I'm constantly assessing. So one of the questions that I ask on a pretty frequent basis was, and let's say that they just found out 2 days ago that a coworker had died by suicide. One of the first questions that I asked them is, what was your first thought when you heard that George had taken his own life? In many cases, people will reveal right there some of the things that they've been dealing with that might have been left untreated. Following the pandemic, a number of people admitted that, well, it reminded me of a year ago, my cousin was killed in a homicide. Because as you know, some cities saw an increase in homicide rates during the pandemic. So I knew right out of the gate, they're in grief. And the question becomes, can I listen to see if they've done any work on that grief? So that's one of the questions that I ask very early to try to get a sense of what's their state of mind. And then one of my follow-up questions might be, when you started your workday today, what were some of your thoughts? So I'm doing a comparison and contrast to what they thought 3 days ago when they found out to where are they today, which gives me another hint as to further assessment. Then a third question that I might ask is, as you look back on the events, besides the actual death, is there one thing you wish you could have changed? And that's the guilt question right there. I wish I had done this. I wish we had done that. I wish I had known this. And then later in the education phase, I start to talk about things that might make it more difficult for some of the workers to handle the current crisis. And I'll go through examples, such as if you've lost a relative in the last few years, if you've lost a relative to suicide or homicide in particular, if it's a suicide situation. I'll also talk about prior experiences with sexual assault or domestic violence. I will talk about how, if you've had to deal with domestic violence in the past or sexual assault, this could be harder when people think, well, how are the two related? In both situations, there is uncertainty, there is fear, there is anxiety. And so if those other situations have been untreated, we add another layer now, the current crisis, and it could be harder for you.
Mhm.
So there are several ways that I'm assessing and bringing to the surface, perhaps, prior situations. Now, it is not a situation, someone might say, I've got domestic violence in my past, or I have a sexual assault, but they can't tell their story in group. First of all, that's not the right place, and they might traumatize someone else. So I really have to maintain influence and control over the direction of the conversation, because
Mhm.
I don't want someone's trauma completely spilling into the group and it affecting all the others.
Wow. You know, it's really interesting because you have me thinking about something. I also do corporate training. And in some of the work that I do, I have this little inventory. It's got about 20 questions on it. And I give it out anonymously. And what it asks is, are you dealing with any of these things? Currently dealing with an addiction, maybe being depressed, maybe having marital problems, maybe being homeless, maybe having money problems. And I have all these things listed out. And I collect it from everybody. And then anonymously, I just say, these are things that people in this class are dealing with. Inevitably, there is never a sheet that doesn't have at least 5, if not more, things checked off. And my point to them is that you don't know what's going on with someone. You see them at work, they're putting on the happy face, but you don't know what's going on behind the scenes. And so all people have things that they deal with that they're carrying around. And so now you have this traumatic event that happens at work that everybody knows about. Well, none of us know the background of each individual person as to how they're responding or why they might be responding that way, right? Because there's all this other baggage that people carry with them.
So essentially, you're asking people to take a world view of others, to acknowledge that there are challenges people are facing or have faced that you may never know about.
Mm-hmm.
And you're normalizing what might be abnormal situations. And then maybe you're asking them to have a little grace when they interact with others, that just because someone has untreated trauma in their lives, it doesn't give them an excuse to say anything. But can you give someone grace as opposed to going defensive?
Right.
Can you ask them some questions about, sounds like you're having a big response, where's that coming from? Or is there something I need to know about this that I don't know?
Mm-hmm. Mm-hmm.
And when I'm working with trauma groups, I ask them to take a trauma-informed lens, as in we don't know the types of trauma that people have dealt with. But we do know that in many cases, a large number of people are exposed somewhere along the way to the unexpected death of someone, a suicide, domestic violence, sexual assault, sexual abuse as children, physical abuse as children. And we certainly never ask them if those things have occurred, but we have to acknowledge a world where those things don't occur and people may be acting out because of them.
Right. Right. Well, so let me flip the script here for a second. You come in as the professional to work with the folks who have been exposed to this traumatic event. It's got to weigh on you. What do you do as an individual to keep yourself healthy?
The first thing is to go in and be as prepared as I can, to trust my training, and to continue to invest in my training. One of the things that I was trained on as we went through the pandemic and as we came out of the pandemic is, how does critical incident work change now that people are working from inside their homes? That you can't go across the hall and talk to someone because you're in your home.
Right.
How might that make it better or worse? Meaning that some people, when I deliver the critical incident responses, they're all at home. They're all working for a company. And some people might say, well, I'm home. I can walk across the hall and talk to my wife or my partner, and that has helped. Other people have said, I'm home alone. And I wish I was in an office where I could go have lunch with Andrew or go have coffee with someone after work. But that doesn't occur, especially in situations where home base is in Philadelphia and I'm working in Waco, Texas, and I'm
Right.
alone out here.
Right.
So trusting my training and continuing to look at ways I can get better and the latest research. I'm very research driven. I want to see some numbers. I want to take a look at what are the trends. So that's one way I take care of myself. Another way I take care of myself is I believe fervently that every therapist should have a therapist. And so I have sessions with a therapist. Also, I have a great relationship with my wife. She helps me. I have close friends. I pay attention to my eating habits. I am a big supporter of exercise. In fact, with virtually every treatment plan in psychotherapy in my clinical practice, part of it calls on the person to exercise, even if it's taking a 10-minute walk or a 15-minute walk. So I'm in the gym about 5 days a week, and also I'm a substitute spin instructor and a substitute water rowing instructor.
Wow. It's a lot.
I greatly enjoy it, and it's one of the things that helps keep me sane. I enjoy a group exercise class. Part of the time I'm taking the class, other parts of the time I'm teaching the class. So I have those components. And then another component is I need to stay in my lane when I do these interventions. If I take on too much or take on the role that I'm a healer here, and what I do here will really set the course for everybody, that I am the linchpin here. I'm not. I'm part of a group of resources. But if I get into that place where I have to try to heal everyone, I am not going to be able to do this work.
Right.
So, given some of the bad things that I'm exposed to, sometimes at the end of the day, I ask myself two key questions. Did I stay in my lane? Did I do the best I could? And on some bad days, if I get 2 yeses out of that, that's got to sustain me to the next day. That's it right there.
Wow. It's gotta wear on you at some times, though. I'm sure you must, be exposed to some things that are just horrific that people just would never want to be exposed to.
But keep in mind, I can turn the faucet down if I want, meaning I can say, no, I'm not available for that intervention. And along those lines, it's important that I get downtime during the day. It's important that I have holidays off. It's important that I go on vacations with my wife. In fact, there's a rule here in our house that as soon as we come back from a vacation, we start to plan the next vacation.
Hmm, great.
So we're taking a short vacation. We're doing about 5 or 6 days out in what is known as the Hill Country in Texas. Now, when I first moved here and someone told me about the Hill Country, it sounded like a horror movie. We're going somewhere and we will never be able to escape. But it is out in the country. It's pretty desolate out there and it's quiet and it's a small community that we rent a house. And so taking that downtime and acknowledging any symptoms of burnout that I might start to show. Because I give trainings on avoiding burnout. I'm part of the experiment, though, also at times.
Right.
So acknowledging any warning signs of burnout and acknowledging that if I've done too many critical incident responses in a row, maybe the next one I say, no, I'm not available.
Wow. I'm imagining that's got to be hard for you sometimes to say no.
Yeah, it can be hard because, we're in a caretaking profession and we're in that kind of profession where it's all about taking care of someone else. And we have to be wary that we stop taking care of ourselves. And in some situations, in the clinical setting, our clients, our patients, our groups get the best of us, and our families get what's left, the rest of us.
Right.
And that's not good for intimate relationships.
Yeah. Well, so then tell me this. Someone is, you know, thrown into a traumatic situation. They didn't plan for it. They didn't expect. They show up to work and something happens. You come in, you do the initial crisis work. What normally can that person expect after that initial sort of shock and reaction?
So let's say it's the unexpected death of a colleague.
Mhm.
I just did one where I went to a company and their senior vice president was killed in a car accident in South Carolina. He was with a friend and there was some type of storm and a car was either disabled or had slid off the road and they pulled over to help the person. And here comes another car. The driver lost control of the vehicle and it killed the senior vice president and his friend.
Wow.
So now people have heard the story. They're coming back to work. And you described the first initial reaction for the vast majority of people, and that is shock. That one of the things we might like about work is there's a certain pattern there. We do some of the same tasks and we talk to some of the same people. And as you know, our brain likes patterns and routine. And when that pattern is fractured, the result is shock. I can't believe it. I mean, I still expect him to walk in. I'm still working along at times and I'm thinking I'll get an email from him. And then I realize, no, I won't. So initial reactions are shock. Sometimes there's anger. And in this particular case, the question would be, well, who would you be angry at? But just because there isn't a clear entity or person to be angry at, it doesn't mean you won't be angry. So some people might be angry. Work-wise, some people might be thinking, I don't feel like working today. I really need to take a half day. Some people will complain about not being able to concentrate. They can't focus. They can't make decisions as quickly. They're making mistakes. Now, in a hospital environment, that can be very costly. And so I spend a lot of time talking about that, making medical errors because you're in shock.
Mm-hmm.
So those are some of the initial work-related responses. I go over them in greater depth. By the time I get to that part of the intervention, some people have already talked about that happening. And so what I do is I reinforce that you are having normal reactions to an abnormal situation. Because some people will be thinking, what's wrong with me? Why am I thinking I'm going to see this person when obviously they're not coming back to work? Why is it that I'm working and I'm okay, and then I see a piece of electric correspondence or an email or a document that has his name on it, and
Mm,
then I'm shocked back into reality that no, he'll never work here again.
right. Well,
So one of my goals there is to normalize some of their work-related responses. And then from there, I segue to what responses might occur at home. And once again, with some companies, people are working at home, that the line between them and their families is maybe 15 feet. And so we talk about responses you might have at home. You might go home and you might be more irritable. If you're a parent and the kids are arguing about something, you may not have as much patience with them. You might take a look at any type of disagreement in the house and think, why is that even important? As compared to that guy I used to work with died, he had 2 children. Or if you're a parent at home, you might be reacting to, well, I know I've met the coworkers' kids, and now they don't have a dad anymore.
mm, wow.
Other situations at home might entail you being disconnected. You might isolate a bit. And we have to understand the difference between alone time and isolation.
Hmm.
A lot of people report a change in eating patterns.
Mm,
In many cases, when I do the diffusing at around 2 or 3 in the afternoon, a number of people, when I talk about a change in eating patterns, and I say to them, a lot of people at this point will say, lunch came and went, and they didn't even pay attention to it. They weren't even hungry. And generally, someone will say, yeah, I didn't even think about lunch today. So we talk about a change in eating patterns as in eating less, and then we'll talk about eating more. And sometimes people will eat more for comfort.
right. Right.
Then we'll talk about substances, that sometimes we gravitate towards substances during difficult times that don't help us, that are harmful. I'll reinforce that alcohol can be a depressant and that drinking excessive amounts of liquor may make things worse.
Hmm.
Some people will smoke more during this time. I remind people that the drug that kills more people in this country than any other drug would be a nicotine tobacco product. 400,000 people a year die. That far surpasses the number of people who are dying from overdoses related to fentanyl.
Right. Wow.
And then we'll talk about sleep, that some people may be having trouble sleeping. And then I'll quickly go over what does that mean? Trouble falling asleep, or maybe trouble staying asleep, or waking up early.
Hmm.
Or some people might be sleeping more. And some of those people might find that they get more sleep, but they still feel like they're in a bit of a malaise. They're a bit lethargic.
Right. Whew. It's a lot of things that can, play into this.
Mhm. There are a lot of factors. It's very nuanced. It can be very complicated. So I always think that a company that brings in a critical incident responder is really on top of things, has a lot of foresight.
Hmm.
But in the vast majority of times, their EAP has offered them this service, but they don't really know what I'm going to do.
Right.
So one of the things that gets in the way is that they will send out an email saying a counselor is coming in or a therapist. And as you know, sometimes people will run in the opposite direction. So when I do a call with them to talk about what we're going to do, I emphasize, don't refer to me as a counselor or a therapist. A critical incident responder is coming in. He's from your EAP. We're going to talk about education and resources. And that's it.
Hmm.
I want to try to get people in to see me, but it's imperative that the company, and in the advanced call, I talk about, here's what we're going to do. That it's going to be a structured conversation. It's not going to be a free-flowing release of feelings. Because think of it for a moment. In what I described for you, there is evidence-based research on stages of a diffusing. That you take the group through a different stage. And the beginning of this is at times about reactions. What did you think at first? What was going through your mind? I never ask people, how did you feel? That's the F word in critical incident response. You don't ask that.
Mm-hmm.
What were your reactions? What did you think? After people have discussed that, and we start to go into didactics, education, etc., if someone wants to enter the room late and then they spill their emotions out, it takes the group backward. So that's why after about 10 minutes, no one comes into the room after that. And I explain that to a company, that we don't want to set the group back.
Right.
And there aren't any questions that just call for a free-for-all with your feelings, because this is not the right place for that. And we don't want to trigger people and then send them back to work.
Yeah. So, you know what? Answer this for me. If an organization has some sort of a critical incident occur, what are some of the biggest mistakes or errors that they can make in their response to that?
Well, the first error, as we talked about, is to advertise this as therapy and call me a therapist or a counselor. I am those things, but that's not my role today. The second mistake is unrealistic expectations. People are going to go into this room, they're going to talk to me, and everything will be okay. That's not real. That's not realistic.
Mm-hmm.
So expectations have to be set. And then there's some logistics, such as sometimes an organization, even though I've asked for a private setting, will put me in a room where there's a big glass and people can walk by and see who I'm talking to one-on-one. We don't want to do that. Sometimes the company neglects, and this is simple, the company neglects to put one of these in the room.
Mm.
People at times cry. And some companies, I'll ask, I always bring my own box of tissues. And then education has to surround, if someone cries at work, it doesn't mean they're paralyzed. It doesn't mean they can't function. Crying is a normal response. You, Andrew, might be amused by, I run group psychotherapy out of my practice, and I take a box of tissues and I drop it on the floor in the middle of the circle. The message is that you can get your own Kleenexes, that crying is a normal response. I also find that at times that the person who is least comfortable with human emotion in that room is the one who picks up the box of tissues and thrusts it in the face of the person who's crying.
Wow.
Right. And then the other mistake that sometimes companies make is that they think I'm in there to handle an assortment of counseling needs. That I'm sent in because someone died in the workplace. But it's okay if someone wants to meet with me one-on-one to talk about their problems with depression or anxiety or PTSD. I can give them some education about PTSD if I think that relates to the incident. But I'm not there to diagnose. I'm not there to do counseling. That is not my role. And sometimes companies need to be very aware of that, because not only does that increase liability for me, it increases liability for them.
Well, so, you told us a lot about the critical response and the things that occur and how you approach it. But I know that you're also an individual clinician with your own private practice. And tell us about, when someone comes to you who may have been part of some sort of a critical incident or something, and they've got this trauma, What do you do with them now? Now you're putting on your counselor's hat.
Mhm.
What do you do as a counselor? How do you work? Tell us the behind the scenes stuff.
Sure. So they need to be thoroughly assessed to get a diagnosis. Assessment takes place with, I may send them a self-report document. Also, I'll interview them, and maybe I use another assessment tool that's interview driven. I
Mhm.
want some measurements. I want to attach numbers to symptoms so we can test and retest. Also, keep in mind that you can't diagnose PTSD inside 30 days of when the incident occurred. That in the first 30 days, people will have normal reactions, and it's called acute stress disorder. So I can diagnose for acute stress disorder, but I don't treat PTSD inside that 30-day window. Let's say we're outside the 30-day window. The assessments have said this person has post-traumatic stress disorder. Now we have to talk about clinically, what is our treatment going to be? I'm real clear on treatment. There's always a treatment plan. One of the biggest problems that when people see me and they've seen other therapists, one of their biggest complaints is, Bill, I didn't really know what we were doing. I didn't know what we were working toward. And I'd ask, well, did you establish goals? In some cases, people will say no. In other situations, they'll say yes. And then I'll ask, did you see the treatment plan? People will say no. People need to know what's happening, especially trauma. A lot of trauma is about a loss of control. Well, I'm trying to instill empowerment and control.
Mm-hmm.
So we will pick a an intervention. And so I am trained on 3 evidence-based techniques. One is called prolonged exposure therapy, which can be done a combination of virtually and in person. And I'm trained on CPT, which is cognitive processing therapy. And this can be done combination, or it can be done entirely virtually. Then I do EMDR. The beginning of EMDR, the first few sessions can be done virtually, but I choose to do the rest of EMDR in person. So right there, you have 3 very different clinical interventions. And one of the things that might decide this is, where is the patient? So I'm in Houston. What if I have a patient in Dallas? That patient is not going to drive 4 hours. So for me, we're not going to do EMDR. They can't see me in person.
Mm-hmm.
We're either going to do CPT or we're going to do prolonged exposure therapy. So propinquity is part of this. Where does the person live? And then with CPT, we have to have 2 sessions a week. Is the person able to have 2 sessions a week? And then also, how much homework is there? With prolonged exposure therapy and EMDR, there's very little work done between sessions. In fact, with EMDR, what you might do between sessions is be aware of any troubling thoughts and use your relaxation techniques.
Mm-hmm.
With CPT, there is homework all the time. Sessions are driven by homework. If the person doesn't do their homework, there isn't much to do in the session besides talk about why they didn't do their homework. So all of those are factors. I walk the patient through using a table. I will either put it up on a monitor, or I'll hand them a document and I'll say, or I'll use a dry erase board. Here are the differences between the 3. One of the things I'm also doing is I want to increase buy-in and decrease dropout rate by empowering the patient to have a functional role in the choice of the treatment.
Good idea. Good idea.
My dropout rates for trauma are very, very low. One part is that they're coming to see me of their own choice, so they're already vested in getting some type of treatment. One of the things that you and I have to navigate is that when we take a look at all counselors in the United States, because we are males, we are in the minority.
Mhm.
And so the question might be, the bulk of people that I see are women who either were exposed to trauma because of military service or were exposed to trauma in some kind of relationship, such as could be domestic violence, sexual assault, date rape, or they were sexually assaulted and sexually abused as children or physically abused. The question becomes, well, perpetrator in those situations more than likely was a male. Why would they see a male? Um, Care to take a few guesses, Andrew, as to why they would choose a male? Put all my credentials aside.
Right.
Why would they see a male?
I'm gonna, my first guess would be that there's something to do with power in there, and maybe they're looking for some kind of reassurance from the power they feel, or some twisted version of what they dealt with. I I don't know.
In those situations, the vast majority of women come to me and they acknowledge that they don't trust men. And it's getting in the way of their ability to have a relationship and also to parent. And as uncomfortable and hard as it is, they will say to me, I need to be in a room with a male. And Bill, you're a male. I don't trust you, but I want to give it a try.
Hmm.
And so many situations, a woman says, Bill, I don't trust you. And my response is, well, I'm so glad that you had the courage to come in here. And let's talk about trusting the treatment as opposed to trusting me as a male.
Wow. Interesting. Yeah, there is definitely I don't know the exact numbers, but when you look at the population of counselors, it's very heavily weighted female.
Mhm.
Um, it's interesting for me in my own practice. I have practice management software, and it gives me data and statistics about my clients. And if you were to ask me in general, what percentage clients do I have that are male or female, I'd say it's about 50-50. And then I look at the data and it's overwhelmingly male over
Mhm.
female. And I guess that is because males in some cases are seeking a male counselor. Um,
Right. And in some cases, women are seeking a female counselor because they don't want to trust a male, which is fine. Sometimes I've gotten calls from a woman who looks at my website, sees that I have a tremendous amount of expertise in trauma, and she'll ask me, can you recommend a female therapist who does EMDR? Which I'm glad to do.
right. Wow. Well, this, I mean, the whole area of dealing with trauma and your personal, unique story of how you got there and the background that you have and the experiences that you have that other people just don't have is really fascinating to me. And, I'm so glad that we've had an opportunity to kind of peel back the layers here and see what's going on. And it's unfortunate that there's more and more people these days that are involved in traumatic situations. But at least there are people like yourself who are trained and knowledgeable and skillful to help them, to get through the beginning part. And then in your case, to get through the latter part as well. What type of success rate do you see with people who come for individual counseling with traumatic experiences?
So we would have to ask, how do you measure success? And
Good question.
one of the measurements is the test retest. So throughout trauma treatment, I'm testing again and again and seeing the numbers drop precipitously to a point where they no longer meet criteria for PTSD. So that's one way to measure success. And then listening to what the patient is saying, listening to them talk about, well, I wasn't able to do this particular thing, like go to the movies and be in a crowd 6 months ago, but now I can do that. I used to get into a lot of arguments and carry with me a lot of anger. Now I'm really not getting into many arguments. It just doesn't happen as frequently. And then, of course, I'll ask them specific questions. How's your sleep? How's your relationship? If we took you to a restaurant and you could not get a seat where you face the entrance, would you stay at the restaurant or would you leave? So I'll ask little questions, and the success rates are high. The dropout rate I took a look at is only maybe 5% a year. The vast majority of people who see me, they stick with it and they have success. So when I take a look at the 95% who stayed with me, I've got about a 95% completion rate and a 95% success rate. Now, part of that, remember, is they're seeing me voluntarily. No one's making them come in.
Wow.
So they want to do the work. And I give them hope. And I'm a fervent believer that trauma treatment can be successful. Otherwise, I wouldn't do it. That for decades, the feeling about trauma and PTSD was, well, we really can't help a person get past the obstacles. We can only help them deal with the obstacles. But with the advent of more researched, evidence-based treatments, more education. So with trauma, if you'll remember from graduate school, you might have had a course or a few chapters on trauma.
Yeah.
So when I finished up and I was licensed, I was not ready to be dropped in a room with a soldier or a Marine who was in Fallujah and got PTSD.
Right.
There's a tremendous amount of training above that that has to be taken. For example, when it came to EMDR, I did a postgraduate certification in trauma psychology from Johns Hopkins, where it was trauma education specifically focusing on EMDR with a 400-hour internship.
That's a
And
lot.
then, yeah, I took additional training from a woman named Edna Foa in Philadelphia on prolonged exposure therapy. And then I went through about 8 months of training through an organization called Headstrong, which serves active duty and veterans, to learn CPT. So it's a lengthy process, and you really have to be dedicated to doing the hard work. You have to find time to do the work. And with some of these trainings, it's very costly. EMDR can cost upwards of $3,000 to get trained. I got trained in your area. There's a great school for EMDR in your area, and they did a great job, but it costs a lot of money.
Yeah, no, I'm with you there. I also got the EMDR training, and it was extensive over several weeks, and then we took a break to practice and then came back for several weeks. Cost a lot of money. And the thing for me is when working with someone with EMDR to see to me, it's sort of like you see there's a certain point where they kind of break through and you can see it on their face. And then to hear them afterwards and what their reports are and how this thing that had been tormenting them for so long was no longer having that impact on them because they were able to work through it. It's amazing. I mean, but it's very gratifying as a therapist to see that you were able to help someone get from, point A to point Z.
Right. It is almost like the transition from black and white TV to color.
Yeah. Yeah. So there's amazing things out there. And like you say, evidence-based therapies that are well studied, that are well tested, that are well proven to help people with all sorts of different types of, mental disorders or mental challenges. And, there's that stigma of, oh my gosh, people are going to think I'm crazy if I see a counselor. And it's just so untrue. People are human, and all humans have issues that they could benefit sometimes from a counselor. And like you said, counselors see counselors. so do I, because it's healthy. It's a good way to work through issues and learn about yourself and learn about others. And it shouldn't be something that's embarrassing or stigmatizing or any of that. It's a healthy way to become even more healthy.
Right. And you and I advocate against stigmatizing mental health and mental health disorders. And every opportunity that we get, especially when it comes to facing the word crazy, even though I specialize in addiction and in trauma, the vast majority of people who see me are wrestling with anxiety and depression.
Mhm.
Could be as a result of a divorce, could be grief and unexpected death in their family, could be a job loss, could be financial problems, could be parenting struggles. So those things don't come under the category of crazy, they come under the category of life.
Yeah, yeah. Well, Bill, you and I could talk all day about these things, and I find it fascinating, and that's why I do this, is to share this information with the public so they can learn more about what really goes on. Um, if somebody wanted to get in contact with you, how would they do it?
The best way would be to reach out to me via email, and it's bill at Prasad, Prasad, counseling.com. Bill at prasadcounseling.com, or they can call me, 281-948-3322. Keep in mind that as far as one-on-one therapy, I could only see patients in Virginia and Texas, but for trainings and critical incident response, the world is completely open. And I'm so glad that you got in touch with me, because it feels great to have somehow played a small role in your development as a counselor. And that's very gratifying for me.
No, it was, like I said, you were the very first supervisor I had in my very first internship. I didn't know what I was doing yet. I was still getting my feet wet in this stuff. And, you involved me, you included me, you treated me as a professional, you taught me. We even did a training together of ethics for one of the counseling associations. I remember doing that with you. So the fact that you involved me as an equal and that you gave me leeway and you gave me rope to be able to kind of feel my way through, but I knew that you were there if I needed you, was really, really helpful, as opposed to smothering me because I was too young, wasn't prepared for counseling yet. So your approach is very helpful, and I've always appreciated it, and I still appreciate it to this day.
That is good to hear, and that contributes to my own resilience. So thank you for that.
Great. Well, thank you for taking the time out of your day to join us. I'm sure people are getting a lot from this information, as have I. And again, for those folks who are in Texas or Virginia and looking for individual counseling, I definitely recommend Bill. And outside of those states, or even within those states with crisis issues, clearly we've got a very highly educated professional here in Bill Prasad, and I recommend him highly. So thanks for your time today, Bill.
Thank you. Bye-bye.
Bye.